everyone. My name is Megan Gutowski, and I did my presentation on the homeless. I made a poster for everyone. I hope you guys can see it. I'm gonna move it around to the different spots as I discuss them, so hopefully you can see it a little bit better. So the homeless are comprised of a wide range of different people from different cultures that have different reasons why they're homeless. Their cultural beliefs, values, and norms can be dramatically different depending on the individual. So each homeless person must be assessed individually. Some homeless people may have adopted new beliefs from the people around them, also known as assimilation or acculturation, while other homeless people may hold on to their own personal beliefs that they grew up with, or they may have completely let go of all cultural beliefs and practices altogether. Some may need a language interpreter in order to assess them properly and collect data accurately. Also, the level of care needed may be different for all of them. Some may have several health concerns, while others may not have any. Or some people will want our help, while others won't want to be helped at all. So, there are different reasons that people are homeless, and the reasons that they are homeless has a huge impact on their cultural beliefs and practices. Some people choose to be homeless and roam around from place to place so that they're free and they do not have to live by society's rules and regulations. They get to be their own boss and go where they want, whenever they want, and do not have to pay taxes or anything like that. Some people find themselves with a loss of income, or a tragedy sets them back to where they do not have money to pay for a place to stay, or they have no choice but to live in their car or in a tent on the side of the street. Other people end up on a bad path that leads them to an addiction that takes control of their lives. Addictions take away their reasoning and moral values and replaces them with a never-ending desire for drugs, and nothing else is more important to them, which makes them give up everything for their addictions, and they end up homeless. Some, depending on what made them homeless, has a huge impact on what type of cultural beliefs and norms they have. So in order to assess their cultural values, beliefs, and norms, there's many different factors to consider. Our textbook, Andrews and Boyle, says there's lots of different factors that are most important to examine. First, we must assess what type of family roles they have, what type of communication patterns they use, how they make decisions. We need to also ask what are their health beliefs and practices related to disease causation, treatment of illness, and the use of indigenous healers and folk practitioners, and other complementary alternative therapies. We have to ask about their patterns of daily living, including work, school, and leisure activities. We must also ask about their social networks, including their friends, neighbors, their kin, and other significant people in their lives, and how they influence their health and illness. It's important to ask which culture, ethnic, or national identity that they identify with, including which languages they speak. We need to know their nutritional practices, how they relate to their cultural practice and health. It's also very important to ask about religious preferences, their health maintenance and illness, and as well as how their religious beliefs may influence their daily living, and taboos or restrictions that might influence their healthcare status or care. Lastly, we need to understand the relationships between genders and relations with other people in the community, as well as their behavior styles, including on how they react to anger, competition, and cooperation. That's all from our Andrews and Boyle textbook. I have another resource here, Marks, Solis, Richardson, Collins, Burma, and Hersherich, 1987, which explains that acculturation is a process of change occurring as a result of contact between cultural groups. And one aspect of acculturation is cultural assimilation. That is, the adoption of by minorities of the larger group's cultural morals. It's page 1315. So in order to obtain an assessment, as a degree of cultural assimilation and acculturation of the homeless, we would have to ask a series of questions to the different groups in different areas. Depending on the area they're living in and whether if they're living around other people or living alone can make a huge difference. There are different types of cultures within the same area, and some people may not be affected by the culture of the people around them. It's commonly proposed that we are a product of our environment, but this is not always true. People can choose to have different opinions and believe in what they want, even if it's not the common interest of the people around them. A survey would be a good way to distribute among the different groups of people and individuals that are living in isolation within different areas of a particular city. We would have to ask all of them about the culture that they grew up in and what were their personal beliefs of their parents and the people that raised them. We'd also have to ask them if they originally adopted the culture and personal beliefs or that they were raised around. Then we would have to ask them about the culture that they're living in currently and what type of personal beliefs that they currently have, so that we could compare the original data to the current data in order to determine if there's been cultural assimilation or acculturation and what they currently are believing in. So I have another reference that talks about their unstable living conditions. It's by Argentaru, Chambers, Gargosis, Farrell, Palepu, Kladowski, and Huang, 2013 states, homeless individuals who obtain housing often have difficulty maintaining it due to factors such as financial hardship, physical or mental health problems, substance abuse, and lack of social support. So they're constantly changing from unstable housing environments, such as temporary housing, hotel rooms, and rooming houses, to being homeless, which leaves them vulnerable to several different risks that can impact their mental and physical health. So the source explains that good quality housing would be expected to provide social and personal stability, protection from the elements, privacy and sanitation, and more reliable contact with healthcare providers, factors which should contribute to improved health and access to care, which is on page number 2 of that article. So the impact that they have on healthcare, well, the treatment for a homeless person is very complex and multidimensional. Each homeless person needs to be assessed individually without stereotypes and judgment. They may have cultural preferences or they may not, but the homeless will require more care than the general population due to an increased risk of health concerns. They have a higher prevalence of chronic disease, including both mental and physical disease. And my reference by Sarahiha Jugovic, some more names that are really hard to pronounce, Erdovic and Sariha, state, currently high morbidity and mortality in this marginal social group is attributed to numerous health risks explainable by the homeless, increased risk of suffering from violence or abuse, reduced access to health care, low hygiene, difficulties in obtaining and storing food, as well as privacy needs for sleep, page 168. So this indicates that the homeless individuals that come into the hospital are going to need treatment for all of these things. They're going to require many different specialties and caring nurses that are patient and non-judgmental. And then their access, their availability, and their acceptability really depends on where they're living. They may be close to an emergency room or urgent care. However, many of them do not have insurance, and they don't go to a primary care provider for regular checkups. And then the last thing I have the strengths and weaknesses, which is they're very resilient, they're creative, and they look out for one another. So the weaknesses that I listed are that they are lacking basic needs such as food, water, shelter. They don't have a sense of security. It's very unsafe, and it's unhealthy because they lack insurance and primary care. So for Watson's Cardozo processes, I chose number 1, 2, 4, and 9 because basically the homeless have a lack of trust in healthcare professionals. And if we as healthcare professionals are being authentically present and provide a loving kindness attitude without judgment, and we can help build a helping, trusting relationship that allows them to trust us so that they can open up, be honest with us, so we can assess them properly and provide them with the best care. Also, when it comes to teaching them, it's really important that we make sure that we're teaching the patient in a language that they can understand, with material, written material to hand out, that they understand that's at the educational level that they're at, being clear and concise, as well as answering questions and providing a demonstration for them. We need to use examples that they can relate to, treating each patient as a unique individual with a caring consciousness of touching and working with the embodied spirit of another's. And then for my plan of care, over here, sorry, just one second. I chose the diagnosis of ineffective health maintenance. I felt like that's a really good overview of a lot of what they're going through. And I wrote there that would be related to the substance abuse, alcohol and drugs, lack of health care, and poor living environment. That'd be as evidenced by withdrawal symptoms, elevated liver, kidney, and cardiac labs, poor hygiene, poor nutrition, and dehydration. My goals for the patient would be: patient will be without withdrawal symptoms before discharge. Patient will have a decreasing trend in their lab results daily. Patient will have improved nutrition before discharge, and patient will be hydrated before discharge. So the different assessments that I listed that I thought were important were, first of all, we need to assess the need for an interpreter. We need to make sure that we're getting accurate assessments from the patient. So we also need to ask them about any cultural beliefs that I need to know about, so we can be sensitive to that. And then I would assess for any shakiness, nausea, sweating, confusion. I would assess their weight, their albumin level, their iron, and their vitamins. I would assess their ALT and AST for their liver function, their bun and creatinine and ammonia for kidney function, and troponin and CK for their cardiac enzyme. I would assess their heart rate, blood pressure, O2 saturation, temperature, and pain level, all the vital signs. And I would assess their urine output and color, if they have a dry mouth, any dizziness, and headache for their dehydration. And then on the back here, I have my interventions, which, depending on, how bad their kidney functioning is, they may need dialysis. They're going to need to be reoriented frequently if they're confused. They're going to need a bed bath, clean gown, and linen to help with their hygiene. We're going to have them on EKG monitoring, IV fluids, which would be LR or 0.9% NaCl. They may need Glucerna if they're not able to eat and they have poor nutrition. We're going to put them on a tube feeding. And then lactulose can help lower the ammonia in their system, and Ativan's going to help them calm down and also helps with seizures. Then there's Zofran for nausea and vomiting, and supplements for any of the deficiencies that they may have. The evaluations that I have listed are my goals. They should really go hand in hand. If everything goes accordingly, then the patient will be without withdrawal symptoms before discharge. The patient will have a decreased trend in lab results daily. The patient will have improved hygiene before discharge. The patient will have improved nutrition before discharge, and the patient will be hydrated. Here at the end, I have my self-reflection and my references. I stated that the homeless population does not just have one culture or one set of beliefs that is common among all of them. They're a very complex group of people that can be from several different areas and have different cultural beliefs. They may have more chronic illnesses, including mental and physical diseases, than the general public. This makes providing care for them a little bit more difficult. As medical professionals, we must be open-minded and assess each homeless person individually without stereotypes or judgment. Some may continue the cultural beliefs and practices that they were raised with. Some may have adopted the cultural beliefs of the people around them, and some may have abandoned all cultural beliefs and practices altogether. We cannot assume anything, and we must be open-minded to everything when providing care to the homeless. And then here at the bottom, I have all my references, the articles, the textbook, and of course Watson's book as well. So thank you all for watching. I'm excited to watch your guys's as soon as they're available, and I hope everybody has a great summer.